Good afternoon, everyone, and welcome to today's webinar hosted by Patagonia Health. Today's webinar topic is billing best practices. My name is Denton, and I will be your moderator for today. If you're not familiar with the GoToWebinar platform, look for the communications box on the right side of your screen. There you'll see all attendees will be muted throughout this presentation. This box is your way of letting us know if you have any questions at all. We'd love to answer any of your questions. And if you have any during the presentation, please enter them into the questions field in that box and we will address them at the end. Our presenter today is Debbie McNeil. She is the Senior Implementation and Training Consultant at Patagonia Health. Debbie has over 26 years of experience in medical administration, coding, and billing. She's certified in medical assisting, coding, and administration. Debbie provides training to medical staff and providers on the most effective billing practices that can help maximize reimbursement for their clinics. She has also worked as a billing and coding consultant for public health departments, making her a valuable asset to any medical practice seeking to streamline administrative workflows and achieve their financial goals. We're so happy to have her join us and share her expert knowledge on billing best practices and EHRs. And without further ado, Debbie, if you'd like to take it away.
Thank you, Denton. So welcome everyone to this happy Thursday. Hope your day is going well. Nothing like a good billing webinar, right? So hopefully you didn't have a heavy lunch and we can learn a lot and glean some information about best practices for billing in a medical office facility. So there's certain rules you want to follow, and following those rules as far as a biller, or even a checkout person or anybody that's in your accounts receivable department, that includes your registration people, because that's the first person your patient sees. And eligibility should be done at every visit. What's important to the insurance company? So we're going to be talking money, right? I know there's a lot of reporting you need within your facility, and there's a lot of information that you gather from patients just for reporting or clinical data or things like that. We're going to be talking about what do you need in order to get paid, right? So it all comes down to the dollar. And real-time eligibility verification is very important to any software or any medical facility because it should be done at every visit. If we gather up all the denials across the nation, the main reason that you would receive a denial would be because the eligibility, either the patient wasn't eligible really for that insurance on that day, or the information you gathered is incorrect. There's human error in everything. So that subscriber IDs, the patient's date of birth, the patient's name, and the patient's gender are all important to a claim that you're filing to an insurance company. Any one of those things could cause denial. And then without the correct follow-up to that denial, it's a very easy fix. Then you've lost that money that that payer could have paid you by doing a simple verification and making sure the information that you have is correct. The next thing that we might see that you would want to have an efficient accounts receivable department is making sure your claim status updates. Where is my claim at? Is it at, have I sent it? Is it at the clearinghouse if you use a clearinghouse? And if it's not at the clearinghouse, is it at the payer? And then did that payer reject it and it's back to me? Or did they accept it and I should be receiving an EOB or receiving a payment for that? Outside of that, you need to make sure you're filing your claims timely. As you know, if you're a biller, your timely filing claims time is getting shorter and shorter, not longer and longer. So, we in the old days, 26 years ago, most all payers were 365 days, and then you got an additional 18 months to submit the claim. That's no longer true. Now we have these MCOs, these PHPs, and these commercial payers that have decided maybe your timely filing should be 60 days from that original claim filing and maybe only 90 days to resubmit after that denial. So know your payers, know when that timely filing is coming up, and make sure they at least get that original claim in to give you that additional time to work those denials. because it's very unlikely that if you get a timely filing denial that you're able to change that. That's just lost money again. So once you have those claims out to the payer, and you've had those postings happen, or that claim has been accepted by that payer, but you've not got paid for it yet, then you want to make sure that you're working your aged accounts receivable report to capture anything that wasn't paid. Is it still out to the insurance? And have you not heard anything within a time period of after 30 days? Have you heard something from your posting and the insurance just denied it? Did you fix it? Did you resubmit it? There's things that fall in that black hole of you're just hoping you got paid for it. Well, we don't want to work like that in a medical facility. That's why there should be an aged accounts receivable report by the last time you submitted that claim, so you know exactly how old that claim is from the time you last submitted it, and that it needs to be resubmitted again, or you need to call the insurance company to find out why is it not paid yet. And then there's effective collection processes. So you have a different collection process for an insurance claim that the insurance is responsible for, and a different collection process for those patients that have not paid their bill that they are responsible for. So it's not just working those aged accounts receivable report, it's also working how much does the patient owe you. And that goes out within your policies of your sliding fees and your rules in case you work at a rural health clinic, an FQHC, a public health department that do deduct proving the patient's indigency and things like that. So all of these are effective processes to have a healthy accounts receivable department. Now, looking at the top 10, we already said incorrect patient information is the first reason that you may not receive reimbursement or you're having lost revenue. Not checking eligibility or the claim being unclean. And what I mean by unclean, it's kind of like you arrive at your mama's door, you knock on it, and your shoes are dirty. She just cleaned the rug. She's not going to let you in, right? Until you clean your shoes or make sure you can walk across her carpet without getting dirt on it. So that is what I mean by unclean claim. Now, those clearinghouses and your payers are going to do a look through, making sure that this claim is clean, making sure all the fields that are required be filled in, making sure whatever your enrollments are with your credentialing and your contracts are set to the correct people. Anything can cue that claim as being unclean. And if it's unclean, it's just like your mama, clean yourself up before you come back in, right? So you have to fix it and resubmit it. All of those are still on your timely filing, because if a claim rejects or for some reason they don't process that claim, they shoot it right back to you and you have to clean it up before you send it again, because they actually have to process that original claim before they consider it denied, which gives you that additional time. And then there's always your coding. We are getting paid, all medical facilities get paid fee for service. Fee for service means a service is a CPT. You're getting paid by the service you offer, and the medical world uses those as procedure codes. CPT codes, HCPCS codes, ICD-10 codes, all of those. If you don't currently have a book for these, I would suggest you get one, or you get a user login and password and get some type of online coding help with that. But you're only as good as your tools, and your tools are your coding books as well as any access to the updated coding. Now, our system will give you what the current codes are. If the code is bad or the code has been deleted, or the code has just been added, we do that in our system for you, but that doesn't give you the description of the code. That doesn't automatically tell you, oh, go in our system and look for this code. Only your books, so you're as good as your tools. Your books are going to give you that information. Your subscriptions to the insurance companies are going to give you that through your email, things like that. Now, the other thing that people don't think about when it comes to coding is local coverage determinations or provider manuals. Both of those will give you exactly what this payer will pay and what this payer is expecting to see on your claim. So it just takes a little bit of time. If you're having a problem with a specific service that you're offering, you get paid fee for service. So you got to make sure you're getting paid for those services. Let's say they stop paying you for a service or they won't pay you for a service. Then you want to go to your clinical coverage policies or you want to go to your provider manuals to see why. It could be because medical necessity, because what's important to coding and billing and reimbursement is making sure this service that you're getting paid for was medically necessary to provide. So sometimes we see a lot of pregnancy tests. You just can't put screening for pregnancy tests. Some state Medicaids will pay it, but most commercials will not, because somebody's just not going to walk into a medical facility and say, give me a pregnancy test without a reason why. Either they're checking med management to keep them on a contraceptive for depo, and they have to check that. Maybe they were late on their depo, or amenorrhea. It's not because their feet hurt. That's not medically necessary to do a pregnancy test because I tell you my feet hurt. So if you go and you put this fee for service as a pregnancy test and you put the diagnosis of foot pain, they're not going to pay you because it wasn't medically necessary. Those clinical coverage policies and those provider manuals will give you what they consider medically necessary, most of the time in an ICD-10 format. If not, they'll describe it in a paragraph or a description of what they consider medically necessary. Next, and one of the other biggest things that I see is no resubmission of the claims. You submit them once, oh, we get paid what we get paid. We don't get paid, we just move on, right? So if there's no resubmission or there's no follow-up, that's just lost revenue as well. That's just money left on the table. So we want to demonstrate in Patagonia Health how we can make your life easier in keeping these accounts receivable. So I'm going to demonstrate the system for just a second. Bear with me. And I'm going to actually go into our demo. And the reason that I'm going into our demo site is because we want to make sure everything is HIPAA compliant, right? So I can't show you an actual user site because then I'm not in HIPAA compliance in this webinar. So things will look a little funny and things may act a little differently, but that's only because it's in the demo site. But at the bottom, there is a navigation bar that I can navigate within the system, and then there's a patient search at the top. So if I'm searching for a patient, I'm going to put in whatever criteria for the patient that I want to find, whether it be date of birth, whether it be the name. Now I see this patient, but I'm going to go directly to her demographics because I want to do that first step I said. Is the name right? Is the date of birth right? Is the gender right? Because those three items are very important to the insurance company, and mainly only those. If you have those right and you have the eligibility, then you're probably going to get that claim to go over successfully the first time without rejecting that. And then we're going over to the insurance. Now, the insurance can be three different types in Patagonia. One could be an insurance that goes to the clearinghouse, that goes to the payer, and then it comes back in auto post. Another may be a contract payer where you want to invoice a company. But all of these should be used for collections as well. So if you want to invoice that company for reimbursement, and then we have self-pay, those people that don't have any other payer type. Right. And the services they're receiving today may not be covered under their insurance. So you don't want to file that through their insurance. You want to notify the patient either by ABN that they may be responsible for this, especially if you bill Medicare, or you want to verbally tell them how much they're going to owe that day, and then they become self-pay, even though they may have a commercial because the services they're receiving that day isn't covered through the insurance. And you don't want that to become an adjustment on the end and miss the reimbursement for that either. But real-time eligibility is very important, and being able to easily access that in multiple areas is very important to a software. So this is just our first shortcut to the eligibility. All state Medicaids will, I hate to say the word all, but most state Medicaids will give you what that subscriber ID is if you don't have it, if you have the patient's name and date of birth correct, and then no ID. It will bring back and give you the ID. Now, If you have the ID, but you're unsure about the patient name, because that can be difficult sometimes, especially people using their preferred name and not their real name and things like that. So most all state Medicaids, if you have the ID, will send back the correct name. Now, for your state Medicaid, if this patient has any other insurance, you need to file that insurance first. Medicaid is always the last payer of resort. So most state Medicaids in their eligibility will let you know if that patient has a other payer, right? So if they have a other payer, it's going to tell you who that other payer is. It's going to give you the phone number, and it may even give you that subscriber ID. The next, if they are Medicare and Medicaid as the primary, right? Then you need to know that. And then you can check your Medicare. And Medicare has those wonderful Advantage plans, right? Just because they have that red, white, and blue car, don't mean that they don't have a Part C plan, right? So Part C takes the place of Part B, and then you need to enter in the Part C. All of this goes back to getting that patient information correct, as well as doing the eligibility. Were they actually eligible for that insurance at that time? So anyway, you should be doing eligibility at each visit for what services you're doing for the patient, right? All right. The next thing that I was wanting to show you is the household tab. So there's certain billing rules and requirements in medical office, right? You get paid for fee for service. You also have contracts with your payers. And in those contracts, it's going to tell you what your responsibility is and what that payer's responsibility is. And in order to deduct, waive any CPT code, fee for service, right? Code that you do, if you want to waive or deduct that code, there's only two ways you can legally do that: proving the patient indigent or a good faith effort in collecting the money. Proving the patient indigent is how many live in the home and how much do you make annually. And then you treat everybody the same within those services or within that program that you offer that policy for. Now, there's some federal guidelines, right, that you have to follow the indigency rules for fee schedules and for sliding fee deductions. And that would be something like Title 10, family planning services, some Title 5s, things like that. But you and your facility would know that, and then you would need to set it up accordingly with the federal rules or your specific rules for your specific facility and treat everybody the same. All right. So now, after we determine, can we deduct this if it is a self-pay patient? Is this a certain policy on this fee for service that we can deduct? And did we do the indigency rule or the good faith effort? Good faith effort is 3 statements, and then it can be deducted or written off or sent to collections, right? That would be your choice, but it would be a good faith effort in collecting that money. So now we're going to go over to the ESB. This is where you want to make sure your claim is correct, right? Because we want to make that claim clean. We don't want a dirty claim trying to go to go to the insurance and just get kicked back to us. So keeping your charge entry or your ESB or electronic super bill is what we call it, clean in your facility. And what I mean is everything been filed timely. Is your rendering provider correct? Is your billing provider correct? Does the CPT codes have a medically necessary diagnosis with it? So when I'm looking at my queue and I want to bring up the past month's worth of ESBs, anything that's been approved is gone. I don't need to see anything approved. It's already created claim. It's already went to the clearinghouse. Already made the patient responsible. I want to see these raw ones as a biller because I want to get my fingers on them, making sure that I have what I need in them. So I only want to see what is in draft or what has been put in reviewed for me to review. So all of these have drafts. So we're just going to use draft for that one. But you can see how I can flip back and forth depending upon the status of the ESB. So I want to make sure this one is a Medicaid one. There's a $125 charge. I open up the ESP, and this is just a raw claim. It's not everything that you would see on a 837P file. That's in the background, but it is what you will see what is you have control over in that 837P. Who is the payer? And this one is inactive, so I need to make sure I choose an active insurance, right? If it was self-pay, what was their household? What is the patient responsibility if they are self-pay? Who goes in the box 24 and 31? So 24J NPI, box 31 is the rendering provider. And is that right? Or do I need to change that? You can also set these up for defaults, but you need to know as a biller, how does it need to default before you train a system on defaulting? Because the system is just a system. The only knowledge that the system has to put this is the knowledge that come out of your biller's head of how it needs to be set up. So you'll want to know what goes in 24J, what goes in box 32, what goes in box 33 are all important to the payer. Here is your fee for service. So here is your charge list. This is your fee schedule. So we have every single CPT, HCPCS code, HIPS code, all of those in the system already ready for you to use. But it will only come up with a fee if it's on our fee schedule, right? If it costed us something and we get paid fee for service for that service. And then we have our medically necessary diagnosis code. We use ICD-10, of course, and it will give you a description here so you can see what that description is. Now, of course, on your claim, the descriptions don't go over, only the code. That's why it's very important when you're documenting a fee for service, an appendectomy for a wart removal, right? Because you send the code, not the description. So the insurance is reading this as your fee. This is what you did, and what you did should match your documentation. And that's another reason that you want a book or you want access to a coding online book. That way you can get the full description and you know exactly what you're doing. If you're relying on somebody that did this 15 years ago and what the description was then, or maybe even a made up code in a prior software system and thought it was a real code, that's why you're as good as your tools. The next is that insurance eligibility verification. It keeps a history here before you submit the claim. So I can see what was the eligibility. If I wanted to do another eligibility, I can do another eligibility. These are real time, and real time means you're going to send that to our clearinghouse. It's going to send it to the payer, and you get that response back usually within 10 to 30 seconds at most. And then it updates here. It also puts who checked the eligibility. Where was the eligibility checked to? What payer did you check it with? And what was that response? And then you can always open that up to get everything that payer would send us. So there's another shortcut to the eligibility. Now we want to timely file this. Everything looks good. So then all we have to do is mark this as approved, and then it goes over to the billing side of the system. And remember when I said we want to make sure those claim statuses, I want to know where my claims are at all time. So now we're leaving our ESB and we're going to our navigation bar to billing. And in billing, it tells us, was the ESB clean or was it unclean? So it goes through its first scrub, right? The more we can scrub this thing, the more likely you're going to get your payment at the end. If something's wrong, you want to catch it now. You don't want to have to wait 2 or 3 days for it to reject or 24 hours for it to reject. You don't want to have to wait for it to come back as denied. So if we can work on some of those things that are incorrect from the get-go and have the system tell us what is in error, why was it unclean, why did it not pass, then we can open up the claim. Now, our claims for this one will be in a professional claim form, which is a CMS 1500 type. Now, there's a lot of magic in the background that you don't see here, but if you are a professional biller and you know what a 1500 form requires and how it looks, this will be very similar to what you see on the red, white paper claim form. And then you can click on what doesn't it like. It didn't like that billing provider. So how does it know that's not a correct billing provider? Because we have tables set up for each facility, what should go into these fields, right? And if this number isn't in any one of the billing providers that we have set up, then it's going to error, right? Because that's not a correct one. Somebody set it up on the ESB or manually put it in on the ESB, approved it, and now it's no good. The same goes for the rendering provider. There's a table. Who are your rendering providers? Who are you credentialed with? By the way, nationwide insurance standards is you credential your providers and you contract your facilities. I run into a lot of times that you contract your facility, but you never credential your providers. So you're either billing incident to your facility as the rendering, or you're billing incident to a medical director or the MD and under their license. But you can credential a lot of different providers, PAs, RDs, NPs, um, all of those, and associate them to your box 33 in your contract, your facility. And that's the best way to submit a claim. That's the correct best way to submit a claim. But we want to know, who do you have credentialed? Who do you bill under for this service? So we have a nice table set up showing us all the providers that are set up for your specific facility that can come over and not error on the claim from the ESB. So it has some fail safes there. You can see how the diagnosis pointer points to the correct medical necessity diagnosis code, and it's very easy to resubmit. So you fix your problems, you submit it again, and it goes through that process. But when I said I want to know where my claims are at all times, I want an in-depth history. When did I approve it? Was it batched up into the 837P file? By the way, we do that every 30 minutes across the nation. So every 30 minutes, we're batching everybody's claims and we're sending out to our clearinghouse so you can get them out timely and you can get your reimbursements timely. But this claim history keeps up with where this claim is at all time. Is it at the clearinghouse? Is it at the payer? Has it been posted? Did it deny? Why did it deny? Can all be found here in the claim history. Also, if I fix something, I want to be able to make a claim note. So if there's any claim notes about this specific claim, you would see that here and it would be attached to that claim no matter where you pulled them up. Now so this was an error. If I go to the billing homepage, it's going to give me a claim status summary. And it tells me for this time period, I have 3 claims in error. Now, if it passes through our system, then it's going to go to the clearinghouse. And the clearinghouse is going to accept it, send us a 270 file, right? And let us know it's been accepted. If the clearinghouse says, no, you're clean, you're dirty, I'm not letting you in, then it's going to reject it. And I want to know, was that rejected at the clearinghouse or was that rejected at the payer? And our claim history would tell us that. So we can see, do we have any in rejection? And then there's a nice little easy way of looking at all the rejections from either the clearinghouse or the payer, or we can see all the errors that never made it outside of Patagonia Health. Rejections are still on timely filing. You're dirty, go back home, get cleaned up, and start this process again, right? So anything that is in rejection is still on timely filing. You don't have that additional time and you're still stuck on whatever this payer, all of them are different, says how long you have to submit the claim. So you want to know where your claim statuses are. Is there any rejection? Is there any in error? Because I don't want a timely filing denial. I take that personally. So that's why it says this claim status is so important for every single claim. Receiving those electronic responses from the clearinghouse and the payer is really important. And you want easy access to it. I don't want to have to print a report, look at my report, then go back and find my claim, and then look to see what it might be an error for. I want to see it right there on the claim that was submitted, right there on the claim that was rejected. And that helps me get my job done timely. All right. So now we're going to go back to our presentation, and we are going to go to managing the aged accounts receivable report and managing what did the insurance pay. Was it denied? Did I correct it? Did I resend it? All those things like that, you want to make sure that you are doing to get all of the money that you're supposed to be receiving. So all of that should be done now in an 835 file. Most all major payers will send a software or a clearinghouse the electronic version of the remittance advice. I like it the way we do it because it doesn't rely on me to post it. It doesn't rely on me to go and click a button to make it happen. I want to make it happen. And then I want to work on it, right? So I want it to happen for me, and then I want to work the posting. Just like you receive a paper RA in the mail, you're going to go through that RA showing, okay, this one got paid in full, but this one did not. Why didn't it get paid? And then you have to scroll to the back of the paper RA, find your code. We use Washington Publishing Posting Codes, which are universal. Find your code. Why did it deny? Then find your claim and then resubmit your claim and do all of that. We want an easy, helpful process that we can do all of that in a streamline of everything we need to do to that claim once it's posted into the system. So let me show you what that looks like in the way that we do it. So from our posting at the top, you have a posting tab, and then we have a manage. Now, not all payers will send us an 835. Most will, but there's always those outlying ones that, are just small. They don't process a lot of claims. Then you have to post those manually. Now, being our demo site, of course, I'm not going to show you a real RA that has real patient information on it. So what we did was upload real RAs, but make the patient identifying information scrambled so you can't tell who the patient is, which then made it HIPAA compliant, and I'm able to show you an auto posting within our demo site. So if I go back to 2015, all the way back to ICD-9, and I go to today, this is just what this facility received on this day. They received 11 ERAs, electronic remittance advice, 835 file in the 5010 format. All that should make sense to you. So one of these, it tells me how much this check was, and two, they can send us multiple RAs and multiple checks in each RA batch. So just so happens Palmetto GBA does that. So we have two checks, one for 528 and one for 482.81, right? I can see them both here. There's a total of 10 claims on this electronic remittance advice, right? If I look at the edit batch for this, it gives me this batch name. It gives me the first check. If I put my arrow over, it gives me the second check and the information about this. Now, this was an automated payment, so it was an EFT was attached to this to the bank, so they sent the funds electronically to the bank. Otherwise, this would have said check, right, for you to post. Now I want to see all 10 claims, because just like if I had this paper RA in my hand, I want to see all of my claims in my batch for this RA. And just like if I had the paper RA, I want to look through this and see, did I have any denials? Here is a denial. So if I open this up, it's going to give me those Washington Publishing posting codes of why this wasn't paid. So if I go here to the COB information, it's going to tell me that it was put to the patient responsibility at some point for the 49 non-covered charge, because we all know if you bill Medicare, Medicare does not pay for family planning services. How does it know this is a family planning service? Because it's a diagnosis that starts with Z30. So it automatically did that. So it looks like whoever was working this at this time probably went into the ledger. Isn't that nice? So now here is our ledger that we have access to look at the patient's bill within the RA. Who would have thought that? So we can see that originally this was sent to Medicare. It made the patient responsible. Then it was submitted to the secondary or auto forwarded to that secondary. And then the secondary came back and posted that. So they had Medicare as a primary, Medicaid as a secondary. They got their payment in full, and now that claim balance is zero. And they closed the claim because they received everything that they were supposed to for that claim. And that's why that claim is in red. Isn't that nice? So then we have other things here that balance to the patient. Just like I said, if you're one of those facilities that slide according to your policy rules, the patient indigent or good faith effort in collecting the money, then you can click on here on the patient ledger and see this patient slides to 20%. But I want to know, does this patient have a secondary that needs to be submitted before I adjust this off to 20% owed? And because we use those Washington Publishing posting codes, then we can automatically send that coordination of benefit information electronically to the secondary without having to print it and attach the primary EOB, without having to manually go in and add the COB information because it's pulling from this posting. I just need to know, do I have any of these ones that have a patient responsibility? Because you can only send the secondary what the primary bills to the patient, right? So if I go here and I hit the secondary pending and search, then it's automatically going to pull all the claims that have a secondary insurance. Now, this one's telling me there's nothing to send to the secondary because this is a zero for the patient balance. It didn't make the patient responsible for anything. But if I look at this posting, it shows me clearly that there was a $294 payment on this CPT. There was a $7 contractual obligation, the difference between the allowed amount and the amount that was billed, and then the patient responsibility of $3. Now, Washington Publishing Posting, or PR, means patient responsibility. The code behind that is a description of why they're making that patient responsible or why they denied the code. So we have a PR1 means deductible, PR2 coinsurance, PR3 copayment, right? So then I need to determine, does this need to slide or go to the secondary? Now, to create the secondary, all I have to do is click on that nice little box right there to create the secondary claim. It's going to pull in the COB information. So if I go right beside that CPT code in these nice little red letters, it tells me PR1, tells that secondary insurance, this went to the patient's deductible and we owe them $3 or up to our allowed amount, right? So then it gives me all the adjustment codes, all the reason codes that you would have found at the bottom of that paper RA, except it's electronic here. And then all I have to do is submit that claim, and then that's gone to the secondary. It's going to make that patient responsibility go to zero, making that secondary responsible for that. Hopefully the next secondary RA that comes over is paid and we can close the claim. Now, because we had all 10 of those, we needed to make sure we resubmitted any claims that was denied. So we have a nice little, let me unselect this. We have a nice little shortcut right to the claim. I don't have to go to search claim. I don't have to go to the patient. I don't have to go anywhere to find this claim to fix it and resubmit it because I can open up that 1500 right here within the RA, right? So I can go here. I can see why it denied in my posting, or I can go to my claim history. Looky there. So we have our 835 received. We can view that posting here. It's the same that you've seen earlier. Gives you those contractual obligations and those Washington Publishing posting codes, right? I can fix whatever's wrong with it. So if it says missing NDC code, I can add my NDC codes. If it says incorrect modifier use, then I can delete my modifier. If it says subscriber ID incorrect, then I can change my subscriber number and resubmit that claim directly from the remittance advice. Now, if I wanted to make a note about that, saying, okay, removed modifier, and resubmitted, then I can add that note. It puts who did this, what was the note about, and the claim ID. So there's my little, you know, how you have your paper RA. Okay, that one paid in full, check. Oh, this one denied. Add a modifier, go to the next one. Oh, that paid. So that's your little note, just like you always had done on your paper RA, right here electronic at my fingertips, that I don't have to go to a file folder for the month of December and go through 200 RAs to find the one I'm looking for. Right? Uh, you know what I'm talking about if you've ever done this long. So then once we've completed all of these steps, we want to weigh in our batch list to say, which ones have I worked? I don't want to have to look at all of these to see which one I've worked and which one I've not. So we have a nice little follow up status. I can mark this as completed, update that, and now in my batch list, I can see the ones that have been completed and the ones that still need to be worked and completed, right? Now, like I said earlier, maybe you were working this really quickly. Maybe you missed a denial. Whatever it might have been, that claim payment goes into this big black hole that you may never get unless you're doing your aged accounts receivable report. So let me go back to our PowerPoint and let's cover what trends should we be looking for on an aged accounts receivable report. If you've never run this, then you need to make sure you're running it as often as possible. So like my boss told me one time when I got my first job at 16, I was just standing there because the rush was over. It was a fast food restaurant, right? So I'm just catching my breath, and they come up to me and they say, well, if you got time to lean, you got time to sweep, right? So if you unlike the life now, right, we're always busy, we all wear multiple hats, but anytime you can pull up the aged accounts receivable report, even make sure you work within your week or work within your day to pull that up and work on it, then it gets to a manageable way that you only maybe need to look at it once a week or once every 2 weeks. But until you get it to a manageable area, you're just going to feel like you're drowning all the time, and there's a weight on your shoulders of what's out there. What don't I know about? What money could I be receiving that I've not, right? And we got like bonuses, right? So that may help you too, but it definitely will prove you're doing your job, right, with a good one. Sorry, I didn't mean to go there. So um, when you're looking at your aged accounts before we run it, I've just got 4 columns here. I just made it short so it's easily seen and easily readable. But you're going to see a column of 0 to 16 days and then 16 to 30. Either way, you have to give the insurance company 30 days to pay before you before you want to resubmit a claim or before you want to call and ask about the claim, right? Because they're going to just tell you it's in process or something, right? So you got to give them at least that 30 days and to get it through the mail, things like that. Once it goes into your 31-day column, then that is old, right? So that's everything that didn't get paid. Either you didn't hear anything about the insurance, the RA is lost, or you got denied, or something should have happened, right? You should have received an EOB or through the ERA and worked that during your ERA before it gets over 31 days. Most all payers now pay within a 7-day period. If not, then you as a biller need to understand your cutoff date and your check write day. Every payer has it, right? If you get me these claims by this time, then that's going to go through our check write for this day and this time. And if that payer is not paying you timely, or you know that payer pays you well within 7 days, and you see that in your 31-day bucket, you know something's up, right? You need to look at the claim. What's wrong with it? Do your detective work, because every biller, every accounts receivable department person is a detective. That's your real title, right? So you're going to find out why and resubmit that claim from there. Now, I know we all get busy and sometimes we can't get to it within that time period and get that resubmitted. So then it's going to go into your next aging bucket, your 91-day bucket. Why is it here before we resubmit it? You just didn't have time to do it, right? But what you want to see is high numbers in your first bucket, in your second bucket, a dramatic decrease, in your third bucket, another decrease. You should never see one go up. It should always be decrease, decrease, decrease to nothing, right? So if your pattern is we have high numbers in our 0 to 30, in our 31 to 90, we have really low numbers, and then an increase in our 91 days, then all you're doing is allowing it to go from one bucket to another bucket to another bucket until it ends up in the dead zone of 121 days plus. 121 day plus is it could be a year old. It doesn't matter. It's over 120 days. Now, if you've not submitted that from the last time you submitted that claim was 120 plus days ago, then what's going on, right? If you're doing this at least daily or every couple of days or a weekly, you want to make sure you have a very low number in this 120 days. Otherwise, it should have already been resubmitted or closed if you've gotten it paid in full. All right. That being said, rip that Band-Aid off. Let's look and see what an actual aged accounts receivable report looks like and why it runs the way it runs. So I'm going to go back to our demonstration in our demo, and I'm going to go to our reports. And this is an aging report and insurance. Now, you have an aging for self-pay. If you are a nonprofit facility and you most all your patients are indigent, you're not really going to get, it's very unlikely you have a high volume of patient payments, right? So it really depends on your clinic. It really depends on how you run, whether you run both your insurance claims and try to collect from your self-pay claims as well. But do these steps not just for insurance if you're wanting to collect from your patients. It is accounts receivable, whether it's patient owed or whether it's insurance owed. We just have those separated out in our system. So we have insurance claims, and we're going to want to run that in detail because I want to see the claim ID, I want to see the patient name, the medical record number, things like that. You're also going to want to run it in pending plus zero payments. So if you've never heard the terminology of zero payments, that's any CPT code that you didn't receive 1 red cent for. So if it's a CPT code that has a charge and it posted at the payment posted, but the payment was zero, that's a denial. So you don't want to just look at what's still outstanding from the payer. You want to see, is there any denials that I didn't resubmit timely, right? So that's why we're going to have anything that the insurance hasn't addressed and anything that the insurance addressed but didn't pay. And then we're going to want to run that by submitted date, right? Because if I run it by date of service, you don't know how old this claim was from the last time you submitted it. You don't know if you gave them 30 days or you gave them 150 days, right? Because you don't know when it was submitted. It may have sat in the ESB for some reason for 30 days before you approved it. You still have to give the insurance 30 days to pay it. And if you run it by date of service, it's going to be in your 60-day column. And it's really not that old because you've not gave the insurance time to do it. So that's why you want to run it by submitted date. Now, our system will only do 3 years. Why? Because that money gone if you ain't got paid in 3 years. So you should be doing a bad debt write-off for anything that is over 3 years old because that is no longer collectible from insurance unless you're waiting on the insurance to do something, right? And then, or you've closed the claim that maybe it was a bundled CPT that they'll never pay. That payer never pays it, but other payers may. So you bill it to all your payers and then you take the adjustment. It's still a zero payment, but you don't you don't think you're going to get any more money for it, then you can close it and then you would exclude it as a CPT code that you know is automatically bundled no matter what modifier you put on it. But we're going to go here to our 2015 just because we have real information in 2015. Everything else is just going to look a little weird to you because we don't actually submit claims to payers from this system, from our demo system. So I want to do what one would really look like. And to see what it looked like back in 2015, I have to put in a reference date. That's the only reason I'm doing this. Otherwise, you would run it for what it actually looks like today, right? Because if you resubmitted it yesterday, you don't want it to see in your 0 to 16-day bucket anymore if you submitted it yesterday. So that's why you want to run it for whatever it says today. So I want to see what it looked like. November 2nd, 2015. I want to exclude my closed claims. I want my patient information, and then I'm going to click search. Now, that might take a second to run. That's pretty old claims. That's a lot of information that it's looking for. Was it paid? Wasn't it paid? Was it posted? Um, or is it still pending? All of those things. Now, when we look at the bottom of this report, we're going to see percentages, and there's always national percentages on what medical facilities should use as a baseline. But you are your own facility. I've never walked into one facility and they all run the same, right? So make your percentages what you feel comfortable with. But as we're going through here, you can see that don't watch the screen. I got to get to the bottom, and that's going to make you dizzy if you watch. So let me try to do this as quickly as possible, because I want you to see the bottom. Right? Okay, so we have our 0 to 16 day bucket. There was 50% of the claims were in the 0 to 15. You should see a dramatic drop, right? Because most payers pay within 7 days. Then the rest of them maybe you're waiting on the paper, or you're something's going on with it, but there should be a dramatic drop here from your 16 to 30. Now, anything over 30, is bad, right? Because anything over 30 means I've not heard nothing from the insurance. I gave them time to do it, and either they denied it, one or the other. And then we go to 18%. So we see a decrease. We want to see another decrease, not an increase, right? And then we want to see another decrease all the way till it gets to 0, which is our 120 days. Because by the time it gets to this bucket, you should have already resubmitted, and it should be back here in this bucket, one of these two, right? So when I say make what you feel your facility is capable for your percentages. Most streamlined primary care practices, those last 3 columns, you do not want to add up more than 10% of your total accounts receivable. Right? And that can be harsh for some facilities. And 2, it's really about how much time you have to devote to this, right? So now we can see who is the payer, how old is the claim. So this has been posted. They didn't pay for the venipuncture, right? Any claims that have multiple CPTs that did not get paid, you would see in a bold and unbolded. So this is one claim. All 3 CPTs did not get paid, and it's in this column. I want to do that last one there because that's a 36415. So if I double click here at the claim, copy that, minus that down, go back up to my search claims, simple, right? I want to search for a claim. So I'm going to put this claim ID here, hit paste, and search. Now, this pulls up this 1500 form. I can see the payer paid some of this, right? So if I open this up, I open up my claim history. I want to see why it denied. So I'm going to go to my posting. I'm going to click view. And then here's my 36415 and my 99000. They didn't pay on either one. And they denied it for 97. I don't know what 97 means in a Washington publishing posting world. I can click the magnifying glass and it will tell me this benefit of service is included with another payment or allowance. So they bundled that with that procedure, right? And then there's no 25 modifier that I can put on here. And then for this one, they made this amount to the patient's deductible. PR1 means deductible. So that was not a denial. That's not why that was processed and put to the patient's responsibility. So then it goes on my patient responsibility collections if the patient doesn't owe it, right? But this one's going to appear on my aged accounts receivable report as insurance because it is a 0 payment. Now, I know this payer is never going to pay me for this because they either pay for the 36415 venipuncture or they pay for the specimen handling fees most often back here in 2015. So then I'm just going to close the claim. right? Because I've gotten everything that I was expecting to get. So I want to open up the patient ledger, find my claim, right? And then close that claim. So if I open up this claim, that's the claim. I can just hit the close, exit out of that, or I could have went to the claim ledger, which probably been easier, and closed the claim there, right? Then I wouldn't have had to search for the data service. But the next time I run my aged accounts receivable report, it's going to be that amount less because I closed a claim and I excluded my closed claims in my accounts receivable. I'm not going to get anything from them. That payer's not going to pay me for that, so I'm going to close it. I shouldn't count it in my accounts receivable. So the next time I run my aged accounts receivable report, that is going to be gone. Now, if there was something wrong with it that I should have resubmitted it, then that $13 would have went right back to my 0 to 16. The next time I run it, hopefully it gets paid and it's no longer on my aged accounts receivable report. So that is how you should manage your aged accounts receivable, no matter what software you use. That's the correct usage for one, not just a tattletale whether it's how old somebody's claim is, right? It's used as a tool and you're as only good as the tools you have available. So let's go over collections a little bit. You, just like I said, a lot of facilities are now nonprofit, right? They see patients with very little income, right? So most of the time, the patient doesn't pay. You don't want 5 years worth of accounts receivable showing like you can receive it. You're living in a dream world. If they've not paid you within that time period, they're not going to pay you unless you send it to a collection agency, which most indigent facilities don't do, right? Or it's going to just stay there and look like you should be getting money you're never going to get. So you should have some type of policy for bad debt. Now, if that patient comes back and they want to see you again and they want to reactivate their account, then they can pay their debt set off amount that was adjusted off and they can start seeing you again. If you have a policy that you can't turn patients away if they owed you money or if you sent them to collections or whatever reason, then you can continue on seeing them and just putting the balance back on their account and let that age again. So that is what is called usually debt set off. These are the things that the patient should have paid, haven't paid within a time period, and I don't want to keep looking at it like a stack of bricks on my shoulders that doesn't matter what I do, I'm not going to get it. And then we have collection agencies. Um, we have facilities which can garnish taxes, right? So if they owe the county money or the state money, then their taxes, their state refund can be garnished for that. And when you can send up reports for your state to garnish their taxes, and then you can mark their account as debt set off, which is then sent for tax garnishment or sent to a collection agency. Before you get to this, though, if you have the time, right, uh, then you can do your collections for your patients using an aged accounts receivable report for patient balances, right? And then you would work it the same way. You would want to see how much do my patients owe me? How old is the balance? What is their contact information? Call them up. Can you make a payment over the credit card right now? Or can you come to the office and pay this, right? And then you can work out PPAs, payment plan agreements. Now, payment plan agreements is an agreement between you and the patient to pay monthly payments or biweekly payments or however it is. We do have a very in-depth PPA, patient plan agreement options within the system. And then you would see in your payment plan agreement, are they late in their payment plan agreement? Do we need to go back through the collection process? Do we need to do a debt set off? Those things like that. We're at the 3 o'clock hour. I know I ran my mouth the whole time. I will leave it up to Denton whether you want to do a Q&A for about another 10 minutes. It's up to him, or if we have a hard stop here at 3. Thank you very much. I hope that you were able to glean something from the webinar today, and hope to talk to you soon.
Thank you so much, Debbie. And we are running a little bit low on time, but I do want to ask a couple questions here. So from the chat, I see one that says, you are working on secondary from the primary remittance post, but they don't enter the secondary until after the claim is submitted. Is it true that it won't come up under the secondary? Does that question make sense?
The primary has to post for you to have the coordination of benefits to attach it to the secondary claim. So yes, the primary should you can't submit a secondary claim without knowing the patient responsibility or the responsibility of the secondary. I hope that answered that.
Awesome. And another question we had was, when you were back on the household tab, kind of explaining that section of everything, do you have to have physical proof of income to complete the household tab?
No, it is your policy within whatever facility you are. For this service, if you say the patient can give you verbal income, then they can give you verbal. You just can't say, okay, Debbie McNeil walks in here, I require you give me proof with a W-2, while Denton walks in here and you say, okay, you can tell me verbally. You have to make it across the board for all your patients the same. You can't make it verbal for some and requirement for paper for others. Verbal all or required paperwork for all.
Awesome. Awesome. That answers that question. And is the household tab also where you check for which services are covered?
So if you do your eligibility, it really depends on the payer what they're eligible for. The best way to know what payers pay what is the billing provider manual, right? But a lot will send us back. Do they cover preventative services? Does this patient have a deductible? How much have they met of their deductible? Things like that. So that eligibility that I showed you earlier in the insurance tab, if the insurance gives us the information, we'll share the information with you. Otherwise, it's pick up the phone and call.
And is the household tab required for a sliding fee scale?
So there's something called the anti-kickback statute, right? And the anti-kickback statute and your contract payers, payers that you're contracted with, will say, if you offer a discount, then you must offer the discount to me as well. That's your responsibility as a provider. So if you're discounting anyone without proving indigency and without a good faith effort in collecting the money, then you have to follow the sliding fee scale according to household and income. Now, if it's a good faith effort in collecting the money, then you would bill the patient the whole amount, and then if they don't pay it, adjust it off. But that's the rules of the game. Whether you do that within your facility or not, that's up to you. But that is anti-kickback statute if you want to look that up, as well as if you want to look at your payer contracts and what your responsibility is within your payer contracts. The only one that is exempt, by the way, for indigency and a good faith effort is rural health clinics and FQ, federally qualified health centers.
Awesome. Thank you so much, Debbie, for sharing all of your knowledge today. We really appreciate it. And for anyone still in there in the audience, be on the lookout for a video recording of this webinar and an email sometime next week. And if you'd like to learn more about Patagonia Health and our integrated EHR practice management and billing solution, you can always visit our website at patagoniahealth.com. But with that being said, thank you everyone for joining us today, and we hope you have a great rest of your week. Take care.